So we went through some special cases concerning calcemia, and now we're going to go through hypercalcemic state, hypocalcemic state, and at the end I'm going to compare different cases, especially aiming on the levels of PTH, calcium, and phosphates. Okay, so first we're going to start with hypercalcemia. So hypercalcemia. And of course, we're going to start with the most common cause of hypercalcemia, which is primary hyperparathyroidism. But watch out, I'm going to talk in details about primary hyperparathyroidism a bit later. So now I'm going to just name the cases. And we already went through them in a previous episode. Okay, so what are the causes of hypercalcemia? So primary hyperparathyroidism. And typically, remember, it is pretty benign hypercalcemia, so we could say mild hypercalcemia, so nothing so much serious, although you do a surgery afterwards. Anyways, what is a serious hypercalcemia is caused by tumors, by cancer. So, and as we talked earlier, there are two main ways how you're going to have hypercalcemia. One, and the more common one, is that the tumors secrete PTHrp, all kinds of tumors, we talked about it. Or it could be invasion of the bone by metastasis. And so remember, metastasis, like remember breast cancer, as we talked about. Or it could be multiple sites, like in multiple myeloma. Okay, so those were cancers. Then we talked about granulomatous inflammation. And again, granulomatous inflammations. So basically any of them, but especially remember sarcoidosis as a, let's say, main example, or you could put TBC or whatever, and you know that there are activated macrophages which are able also to transform vitamin D into its most effective form, that's calcitriol. Special thing is long-term immobilization, which you can see long-term immobilization that you can see in older people. So basically in old people, either you can see hypercalcemia due to resorption of bone because you're not using the bones, you're laying down in a bed. And on the other hand, you don't have enough of sun, so you can have hypocalcemia. So it depends, of course. Okay. Then another cause is, as we talked about, hyperthyroidism. So Graves' disease. Okay. Again, there's a theory that there's activation of osteoclasts through T3 and T4, whatever. But we see that T3, T4 increased. Then there is the special case of familial hypocalciuric hypercalcemia, which is pretty much the hallmark. Remember, if you have hypercalcemia, normally you should get rid of calcium through urine. But in this case, when there is a mutation of the calcium level sensor, this is what you see typically. Then we mentioned thiazide. So remember thiazide diuretics. This is a side effect of these diuretics, which increase resorption of calcium in the distal tubule. That's why we have hypercalcemia. And of course, pretty rare case of intoxication detoxification by vitamin D, but this is possible, and it's very similar to sarcoidosis, as we talked about. Okay, so those were the causes, and let's get to signs. So signs of hypercalcemia, and typically what you're going to see CNS sign, because the CNS is going to be depressed. You're going to be lethargic. You're going to be tired. Okay. Also, your GIT tract, your intestines will be lethargic in a way. So there's going to be constipation, abdominal pain. Patient can vomit. Okay. And remember, there could be pancreatitis in connection with increased calcemia. But remember, if it's a serious pancreatitis, we're going to have rather decreased calcemia, because all the calcium is going to be blocked in the inflamed pancreas. So it's going to precipitate over there. Okay, so this is in cases of light pancreatitis as a cause of the pancreatitis, very likely. And what about kidneys? Well, kidneys, over here, watch out, there's going to be, and why? There's long-term hypercalcemia, which causes, of course, let's say resistance of the ADH receptor. So you're going to have polyuria and polydipsia. You're going to drink a lot, and watch out, there could be stones in the kidney. So that's pretty dangerous. And on ECG, what you will see is a shortened QT interval. That's important. And what is the treatment? Well, treatment, just in few words. First of all, remember, you have to give lots of infusions. You have to dilute the calcemia. So first of all, you give infusions. If it's a really serious hypercalcemia, you can also use calcitonin. That's in case of metastasis, plus with a combination with bisphosphonates. Both block bone resorption. Calcitonin does it early, and bisphosphonates, it takes them 1 or 2 days. So you give them together, and then you continue with bisphosphonates. Okay, and remember, if you overload the patient with ringer lactate or with saline, and if there are edemas coming on, so if there is a fluid overload, remember, you should also later give furosemide to get rid of the water. Okay, so this is a general treatment and general view on hypercalcemia, and let's get to primary hyperparathyroidism. So primary hyperparathyroidism, and we talked about it already, primary hyperparathyroidism. So this is the most common cause of hypercalcemia. And in 80% of cases, it's a single adenoma. Okay. In, let's say, 19 or 20 other percent, it could be hyperplasia of all four bodies. Okay, and in the 1%, if we talk about 19, then remember, it could be in combination with MEN1 or MEN2. In case of MEN1, although 2 you divide, but doesn't matter for now. So remember, it's a primary hyperparathyroidism with combination of tumors of hypophysis plus tumors of pancreas. pancreatic tumors. In men too, it's again primary hyperparathyroidism with pheochromocytoma plus medullary carcinoma. Okay, this primary hyperparathyroidism, it's very rare in combination with M1 and M2. Okay, and what are the signs? Well, of course, they're going to be just the same as with hypercalcemia in general. So you should remember, it's a mild hypercalcemia. And in this case, yeah, CNS is going to be depressed, so lethargy and whatever. Then remember, because of kidneys, there's going to be polyuria, polydipsia, and remember the stones. There could be nephrocalcinosis. Okay, and in GIT tract, there's going to be constipation, abdominal pain, and of course nausea and vomiting, etc. Vomiting, that's possible as well, although that's rather rare. And what is the treatment? Treatment in case of obvious adenoma with signs, or if it's a young person without signs under 50, always surgery. Get rid of it, surgery. Watch out in case of surgery. What you can see later, it's the hungry bone syndrome. So after surgery, when you take out the adenoma, what can happen is that bones will absorb all calcium and you're going to have hypocalcemia. That happens on first or fourth week after the surgery. So think of that, okay? And of course, if there is no surgery, then again, fluids plus later furosemide, okay? But first you give fluids to dilute everything. So that was primary hyperparathyroidism. About the secondary and tertiary we talked about already. Well, and now the cases of hypocalcemia. Okay, so first of all, remember it is after surgery. After surgery, that can be really serious. So when you get rid of adenoma, or if you do a surgery of the thyroid gland and they accidentally take all the parathyroid glands together, then you can have a serious decrease of PTH with decreased calcium and increased phosphate. Okay. The other cause I would mention decreased vitamin D. So if there is no vitamin D present, so no sun, if there is malabsorption, but what else? Remember kidney insufficiency or renal insufficiency. Okay, so if the transformation is renal insufficiency, so if there is no transformation to the most powerful form, which is calcitonin, or the kidney failure, end-stage renal disease, yeah, of course, you're going to have decreased levels of vitamin D. So this is crucial. Remember kidney especially. Okay, that's very important. All people which are on dialysis, they will have problems with vitamin D in case it's a chronic problem. Okay, not in the acute phases, but if it's acute kidney failure, you don't have to worry about vitamin D. But if it's a chronic failure, then you have to worry about vitamin D and calcemia. There's going to be hypocalcemia. What is the clinics? Well, signs. So typically, if there is a decreased level of ionized calcium, then you're going to have increased neuromuscular irritability. So what's that? Well, that means you're going to be prone to tetany, spasms. Remember, laryngospasms, that could be serious, and different cramps, okay? And also epileptic seizures, watch out. So there's increased risk of epileptic seizures as well. And what are the typical signs? Remember Chvostek's sign. That's when you use neurological hammer and you knock on the masseters, they will contract. Or we can talk about Trousseau sign. That's if you put a tourniquet on the hand in 3 minutes and then you cause ischemia sort of the hand, then typically the metacarpophalangeal joints there will flex, and there's going to be extension of the other interphalangeal joints. Okay, and what about the ECG? Well, ECG, it's going to be prolonged Q2 interval. Okay, so those were the signs. And how do you diagnose, or what you should do before? If you take blood and there's decreased total calcium, remember, first of all, you don't panic. And first of all, you're going to check albumin. Okay, so if there's hypocalcemia, total hypocalcemia, so always you check first albumin. And if the albumin is decreased, then it could be only pseudo hypocalcemia. So you wouldn't care so much about this because that's only decreased total calcium, but the ionized is normal. So there will be no signs and there shouldn't be increased irritability at all. So you first always check albumin. Okay. Well, and then if it's decreased, if the calcium is decreased, then you can check PTH. And if the PTH is decreased and there's combination of decreased calcemia plus increased phosphate, you can be pretty sure it has to do something with decreased levels of PTH. So it could be after surgery or whatever. If there is decreased calcium, but there is increased PTH, what you could think of is you could check vitamin D. Vitamin D metabolism, because then it's nothing else than a secondary, there's decreased calcium and there's going to be increased PTH as a secondary hyperparathyroidism. So normal physiological reaction, that would be secondary. Okay, and in this case, if the PTH is high, then phosphate's going to be decreased if the kidneys are working. Okay, but still, the same way as you would check albumin, also always check, don't forget to check magnesium, because magnesium is very important in terms of secretion of PTH. If you don't have enough of magnesium, there's going to be a problem with PTH secretion, so check that out. And also there's a decreased effect of PTH on the receptors in osteoblasts or whatever, so watch out. Also in bones, the resorption will be not working because of decreased magnesium. So always check also magnesium if that is not the cause of hypocalcemia. So you give magnesium and should normalize. Anyways, in case it's a severe hypocalcemia and the person is at risk of tetany and whatever, remember treatment. If you need to normalize it very fast, then you give IV calcium gluconate. If you have time and the hypocalcemia is not as severe, you give per-os tablets with calcium. Okay. So that was about hypocalcemia and how to treat it, just a few comments. And last thing is the table where we're going to compare everything. So in case of primary hyperparathyroidism, so primary hyperparathyroidism. So over here you would expect, of course, high PTH, and this is the only case where there is high PTH, high calcium, plus decreased phosphates, if the kidneys are working fine. The second thing is going to be malignity, or malignancy as you want. And Over here you got two causes. First, it could be the PTHrp, which is most common, and then you would expect the PTH would be low because there is an effect of PTHrp. Calcium is going to be increased, and phosphate is going to be decreased. Okay. In case the reason why you have hypercalcemia is bone invasion and lesions of the bone, then you should expect decreased PTH, increased calcium, and rather, because there's a lesion of the bone, phosphate's going to be up as well. Okay. If you have not enough of vitamin D, so vitamin D deficiency, this means there's going to be hypocalcemia, which triggers, of course, secondary hyperparathyroidism. So PTH is going to be high, and in this case calcium is going to be low because you're trying to fight the decrease and it's low, and phosphate is going to be low as well. If you have sarcoidosis, this is very similar to vitamin D intoxication, which is actually the same case. So in both of these cases, it's going to be the same. So there's going to be decreased PTH because you have lots of calcium and lots of phosphate. There's going to be increased calcium, and there's going to be increased phosphate. If you have pseudo hyperparathyroidism, that means you are resistant for PTH. Your receptors are resistant for PTH. So PTH is going to be high, but without any effect. So calcium is going to be decreased, and phosphate is going to be increased. And last, kidneys. And this is, there's a big difference if you are just insufficient, so with some mild function and filtration function of the kidneys. PTH is going to be high because it's going to try to fight the decrease of vitamin D. So PTH is going to be high, but calcium is going to be low because you're not getting enough of vitamin D and resorption, and phosphate is going to be low as well because there's still some filtration going on. But there's going to be end-stage renal disease. PTH is going to be high because it's trying to fight the hypocalcemia. So there's going to be hypocalcemia in this case. But you are not able to get rid of phosphate, and phosphate is going to be increasing because there's anuria. No urine at all. And that's it. So thank you for your attention, and see you some other time. So thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.